Hello everyone, now I'll be discussing question on cardiology. So we have a 68-year-old man and he has a 3-week history of progressive dyspnea, orthopnea and lower extremity edema. There's a past history of hypertension, type 2 diabetes, myocardial infarction 8 years back and congestive heart failure. Currently, he is taking metoprolol, digoxin, enalapril, furosemide, spironolactone, and aspirin also. BP is fairly controlled, pulse 75, and there is edema is there, holocystic murmur, maximal, even apex beat has been shifted to more left, and there is holosystolic murmur at the apex. Bilateral crackles are there, and lab results are as follows. There is mild edema is there, and sodium is definitely hyponatremia is there. We know very well the normal sodium is 135 to 145, here 128. Potassium is slightly on the higher side, and rest reports are normal. Well, if ECG shows normal sinus rhythm, and there is no acute ischemic changes. Now, most likely accurate about this patient condition at the moment is hyponatremia indicates severe heart failure. As we have seen in the report also, the patient's sodium is 128 milliequivalent per liter, or say 128 millimole per liter, but that is again an indication of severe heart failure also. Why this answer? Why not others? So, hyponatremia indicates severe heart failure. It's a very, very important parameter. That means whenever we are taking any case of CHF, serum sodium should always be investigated. Now, this patient clinical condition are consistent with decompensated congestive heart failure. And this is due to left ventricular systolic dysfunction. Now, the points which are really favoring this patient has dyspnea on exertion, orthopnea is there, lower extremity edema is there, displaced apical impulse on to more toward left side, bilateral lung crackles, so all these are really supporting also that patient has got systolic dysfunction. Now, hyponatremia in a patient with congestive heart failure, it parallels the severity of heart failure and an independent predictor of adverse clinical outcome. So now you can imagine how significant is looking for hyponatremia in a patient of congestive heart failure. Well, now one more. I will stop the video, write down the answer. I have a question for you. Write down the answer in your copy. In patients with congestive heart failure lead to neurohormonal activation with the release of which molecules? There are certain molecules which are released which lead to hyponatremia. Write down the answer in your copy. Well, in patients with CHF with low cardiac output, and that lead to decreased perfusion pressure at the baroreceptor and renal afferent arterioles, and that lead to release of certain molecules, renin, norepinephrine, which is option D also, and secretion of ADH, antidiuretic hormone, or also called as vasopressin. So these are released and they lead to all the problem what the patient is having now. Now, as far as ADH is concerned, which is, as I told you, vasopressin, it bind to V2 receptor in the renal collecting tubule and it promotes water reabsorption. Okay. Well, again, I have one more question for you. Stop the video, write down the answer. It only, well, if you go into the nephron, and this is the collecting tubule where the ADH comes and it absorbs pure water. It only absorbs water, it has got no effect in sodium or potassium reabsorption. But in addition to water, it absorbs certain other molecule also. Write down the answer in your copy. Which other molecule is absorbed by ADH? Answer is urea. Okay. So we come back. Well, regarding renin, which act via angiotensin II, and norepinephrine increase proximal sodium and water reabsorption. Well, these two molecules, they tend to absorb water at the PCT. So the amount of water reaching in this distal tubule is reduced. Okay. So limit the water reabsorption, delivery to the distal tubule. These actions promote free water retention and lead to dilutional hyponatremia. As the water coming is very less to this place, more and more ADH will be released, and that will cause more and more water reabsorption, and that lead to dilutional hyponatremia. Now stop the video, write down the answer. I have one more question for you. Okay, what is the best initial therapy for hyponatremia in congestive heart failure? Write down the answer. Well, the right answer is restrict water intake. Okay. The first thing you have to do, of course, we restrict sodium also. In congestive heart failure, we have to restrict sodium and water, the first thing. Well, now let's look into other option. Option B is incorrect, that increasing sodium intake will help to control electrolyte abnormality. No. As I told you, the first thing is to restrict water intake. Is the first thing that you got to do. And of course, we also restrict sodium also, less salt and less water. But even this is the first thing that we have to do it. Okay. Now, as far as salt tablet, okay, in addition to fluid resection, can be used in patient in SIADH. This is a very, very important point. So we get hyponatremia in SIADH, we get hyponatremia in congestive heart failure. Of course, in SIADH, we restrict water intake, but and we give salt tablet we can give. But in congestive heart failure, we restrict both water and sodium intake. That's a basic difference in the management of hyponatremia in the two conditions. Salt should not be used in edematous patients with volume overload, like in congestive heart failure. They are already volume overload. So salt tablets should never be used. Now, option C, increasing the dose of digoxin may be indicated. No indication. High digoxin level may increase risk of toxicity, and there is no evidence of improvement of symptom or outcome with decompensated congestive heart failure. As I told you, there is a reduced renal blood flow to the kidney, and that can further aggravate the toxicity of digoxin. So there is no role of increasing digoxin in congestive heart failure. Well, option E, combination of furosemide and enalapril is the cause of hyperkalemia. No. Well, low distal sodium and water delivery in CHF lead to reduced potassium excretion, and subsequent it can lead to hyperkalemia. That's why in our patient also, the potassium level is high. It was 5.3 millimole per liter. That's the reason. Now, when you are using furosemide, which is a diuretic, it causes increased potassium excretion. Rather, when we use fusamide alone, it can lead to hypokalemia also. Now, ACI causes hyperkalemia as a well-known side effect. So, when we use a combination of fusamide and ACI, it will increase cardiac output, and correct electrolyte abnormality. It will not lead to hyperkalemia, will not happen, because this is causing hyperkalemia, this is causing potassium loss. So the hyperkalemia will not be a feature. And definitely cardiac output because with this treatment, lungs will get decongested. By the use of fusamide, it will reduce the preload. Fusamide will reduce preload. And when we are using ACI, it will reduce peripheral resistance. And reduced peripheral resistance will lead to increase in the cardiac output. So, golden line to remember: poor prognostic factor in systolic heart failure. The clinical: higher NYHA functional class 2 and class 3 and class 4, resting tachycardia, S3 gallop, raised JBP, BP low, mitral regurgitation may be moderate to severe, low maximum oxygen consumption. They are all the clinical finding. Lab finding: hyponatremia, very, very important, elevated pro-BNP level and renal insufficiency. ECG QRS prolonged more than 120 millisecond and left bundle branch block pattern. They are all poor prognostic factor. Echo: severe systolic dysfunction that will lead to reduced ejection fraction. Concomitant diastolic dysfunction, reduced right ventricle function, pulmonary arterial hypertension, associated condition like anemia, atrial fibrillation, and diabetes mellitus. They are all indicator of poor prognosis in the case of congestive heart failure. Thank you very much.